Okay, on with the CE. It is my pleasure to introduce Zoom Heaton. Zoom is a graduate from the University of South Carolina in 1992 with a Bachelor of Science in Pharmacy. In 1997, she received her Diabetes Management Certification from the Medical University of South Carolina. And and then received her National Certification in Diabetes Education in 1999. In 2003, she started the TLC Medical Center Pharmacy, and that's the Tender Loving Care Pharmacy in Aiken. We're not competitors, we're just friends. And then she has added, since she opened, a custom prescription compound shop, and she's still currently working on her certification in clinical nutrition. It is with pleasure that I introduce Mr. Zoom Heaton.
Y'all hear me? Awesome. We are at the Grove Park, y'all. Is that not great? Woo! I just wanted to see a number of hands here to see who I'm talking to. Is everyone here pharmacists, or are there technicians here? All pharmacists? Okay, awesome. Just an idea of who I'm talking to. Has everybody here heard of bioidentical hormones? Can you hear me?
It's working.
Oh, everyone here heard of bioidentical hormones? Okay. I need to slow down, don't I? Okay, awesome. Okay, we're going to talk a little bit about bioidentical hormone replacement therapy and nutrition and compounding in practice. A show of hands again. Are there any compounders in here, or anybody wonderful? Anyone contemplating hormone management, perhaps, in their practice? Anyone doing it now? Okay, awesome. Well, I'm going to talk a lot about it, and it may just inspire some of you to perhaps get interested in it. Okay, everything that I'm going to be talking about today is basically my opinions, my views, and my clinical experience, collaboration with practitioners for the care of my patients. So just know that this is not for diagnosis or treatment of any kind without the advice of a practitioner. Okay, so we're going to go through a full panel of hormones today. That kind of gives you the basics of hormones before we get into bioidentical hormones. And we're going to talk a little bit about stress and hormone imbalance, how that affects hormone imbalance, and some natural supplements, and how to incorporate bioidentical hormones into your practice, and how to market the services. Okay, when I was asked to speak, I started thinking, well, gosh, I got inspired to do the HRT in my practice. And I thought, I don't know who I'm going to be speaking to. What if there's somebody out there who's kind of on the verge, who's kind of looking into it, but doesn't have that push, to get you over that little hump to where you decide, hey, this might be the avenue for me. And so I thought, well, the Wizard of Oz kind of came to mind, and the theme of the Wizard of Oz, of course, for me, is self-belief. Because a lot of the characters needed something that they thought, they needed something they thought they didn't have. But yet they had it from within already. And I'm just here to kind of help you to believe that you've got it too. Of course, the Scarecrow needed a brain. Well, he thought he needed a brain. But he's got a brain. And all of us here obviously have a brain. Well, the lion needed courage. He had it all along, right? But this is the thing. We have so much education, we have so much knowledge, but a lot of times we don't have the courage to get up there and get out there and talk to somebody and share that information. So, you know, we need a heart. And once you find that compassion and that care, it's amazing. It kind of pushes you. It gives you that courage to get out there. And you can find it to sit down with somebody and give them the information that you know so that it can help them. And with that in mind, without a heart, I can never really know what it would be like to love someone. And that's when it started for me. Okay, so let's get started with hormones. Hormones are chemical messengers that basically are needed for all of our cellular activity. They are the most powerful molecules in biology, and optimal levels are needed for quality of life. So I don't really understand if we have a decline in hormones, how can we function? Okay? All right, these are just some examples of hormones in the body. Of course, it starts in the brain. You've got hormones there. You've got hormones everywhere. And these are some key hormones in the body that I'm going to talk about in a little bit. Thyroid, obviously metabolism and body temperature, insulin, glucose regulators, cortisol, the stress hormone. That is most of everybody's downfall right there, is that cortisol. Pregnenolone is our memory hormone. I love pregnenolone. And sex hormones, obviously, for reproduction, bone building, memory, libido, vitality, immune health, everything. Okay, this is the hormonal cascade that I always kind of refer to. And I actually have a more complicated chart that is blown up in my office. And the reason why I have it up there isn't because I want to teach my patients. Because they look at that and it's just like, whoa, why am I even looking at this? But the only reason why I put it out there is because I want people to see where hormones come from. And we don't think about it. And most of America is on a statin. So what are we doing? We're suppressing cholesterol. So we're not making our hormones properly. And that's why, if you think about it, our risk for every degenerative disease is on the rise. Okay. All right, let's start with sex steroid hormones. We're going to start with estrogen. It has 400 crucial functions in the body. 400. Everybody's so scared. Oh gosh, no more estrogen. I'm like, well, you know, we kind of need a little bit of estrogen just to get our bodies going. You got to have estrogen for brain function, estrogen for libido, bone health, cardiovascular health. Without it, women, you will never have the urge. And you know what I mean. Okay, there's about 20 different forms of estrogens in the body, but these are the only 3 that I'm going to mention today because these are the top estrogens. Your estradiol is the most potent. It is primarily derived from the ovaries, and when you've got a deficiency in estradiol, that is when those symptoms come. That's when you get the hot flashes and the night sweats, and you can't sleep, and you have vaginal dryness. And you don't like that. Estrone. Estrone is produced in fat cells. And that is the most carcinogenic, cancer-causing hormone. Estriol, my favorite. It is a weak estrogen. However, it is the most protective. against breast and uterine cancer. And you're not going to find it. The standardized, you're not going to find it at all when it comes to this pharmaceutical oil. Okay, so what is estrogen dominance? I talk about this all the time. A lot of people get confused and they think estrogen dominance just means, oh, I've got more estrogen than I'm supposed to have. But that's not really what it means. It was a term that was coined by the late Dr. John Lee, who was a pioneer of bioidentical hormones. And he basically is saying that you could have a normal amount of estrogen, a deficiency, or an excess of estrogen, but it's not well balanced with progesterone. That's what he means by estrogen dominance. And when you have estrogen dominance, it does put you at risk for breast cancer. Okay, so what are the common symptoms? Anybody have any? Anxiety, irritability, I see that a lot. Fibrocystic breast mood swings, depression, weakness, food cravings, joint pain. A lot of people come in and they're just like, my life is over. My husband doesn't like me. I think we're on the verge of divorce. My children came up to me and said, "Who took my mommy?" Sorry. And I see all these symptoms. Okay, estrogen deficiency. So when you don't have enough estrogen, you get all of these symptoms. You notice they overlap. And this is exactly what they tell me. And I'm like, I don't want to hear it. Because I'm liable. I didn't hear what you said. Sometimes I just want to shoot everybody. I'm like, okay, nope. I want to see your face on the front cover of the Evening Standard for national news. Okay, so we need to restore estradiol because it eliminates all of your major symptoms, your hot flashes, helps you sleep, it protects you from cognitive decline, improves mood, gives you that thickness and fullness of skin and hair. Protects against colon cancer and macular degeneration. It prevents atherosclerosis, hypertension. Improves insulin sensitivity. So it helps with diabetics as well. So estrogen is wonderful in physiologic level. Okay, progesterone. This is my favorite hormone. I call it the healing hormone. It is an anti-estrogen. You have to have something to oppose that estrogen, or you will get estrogen dominance, and that's going to put you at risk for all of these issues, cardiovascular, breast cancer. It balances estrogen. Oh, it helps to sleep. I've got people, I think that is probably the number, I'd say the number one problem. People come in and say, I need help. I cannot sleep. I was sleeping fine, and then all of a sudden, it's just like I'm waking up in the middle of the night. Sometimes I'm hot, sometimes I'm not. But I'm waking up, and I can't sleep. And you can see all the darkness down here. I need to walk over here because I don't want to be on the middle and be reflected. Helps build bone. And I've got a lot of people who actually do a lot of their own research and a lot of their own reading, to where they're discovering that a lot of these hormones help to prevent degenerative diseases like osteoporosis. So, they're coming in just to say, listen, I don't want to keep on synthetic hormones. Will bioidentical hormones help me to build bone? Will it help me to prevent dementia? Yes. Helps with bladder function. I get a lot of that. Incontinence, bladder issues, mood swings. Yep. This is how it is. Okay, and there are a lot of evidence, a lot of clinical studies out there that do say that progesterone is the one hormone that is an anti-estrogen that is very protective. And there is going to be a lot of clinical evidence that are in these slides that I am not going to go through because a lot of it you guys can read. And the only reason why I put it in there is because if you decide to do this, and let's say that you found a practitioner that is open to it, they're probably going to want more documentation. And so you can just pull all of these studies out and say, listen, doc, it works. I can tell you, this is the evidence. It's not going to kill people at physiological levels. It's not going to hurt them. More clinical data on progesterone and how protective it is against breast cancer. And if you notice here, the higher the progesterone level, the lower the risk of breast cancer. More data. Okay, testosterone. I get men coming in. Well, you know, the first thing is just want it for libido. They're not even thinking about bone health. They're not thinking about, prevention against dementia or cognitive decline. But you know what? There are some men who come in and say, listen, I'm starting to feel really, really tired. I can't function. I don't have the energy to even go to the gym. Low testosterone. And just remember, testosterone is not your trigger hormone, women, for libido. It's actually estrogen. So if your estrogen is not well balanced, you're never going to get there, no matter how much estrogen I throw at you. Now, as far as men, that's their trigger hormone. So yes, when they're low, their symptoms are going to come. So there we are. Low testosterone, those are the main symptoms. People get very depressed. And with women, they generally gain weight in their abdomen. I see it all the time. Starting around age 40, 45. Tired all the time. Okay, DHEA, made by the adrenal glands. This is the number one hormone that leads people to look and feel older. When they come in, that's one thing they tell me. Why is it that I went from feeling good, exercising every day, doing the normal things that I want to do, to just aging? Like I don't want to get out of bed, I don't feel good about myself, I'm gaining tons of weight for no reason. I mean, I do everything that I'm supposed to be doing. I'm walking every day, or I'm in the gym every day. I'm eating normally, and I'm eating healthy. I'm eating a lot better. Which, of course, I have to kind of do some detective work and go, okay, what is better than really eating? And without DHEA, your immunity goes down. It does reduce insulin resistance. It counteracts cortisol effects. It reduces pain. And there have been people who have come in having a lot of aches and pains. And there was actually this one person that comes to mind right now, a man, who came in and said, it's really funny. I have this, and he's a golfer, so his hand was hurting, like right in here. He said, the pain would be off and on, but it's gotten worse. And I just don't know why that is. Well, his DHEA and testosterone were low, so we supplemented him. About 2 months later, in his follow-up, it was like, I don't know if this is even part of the hormone therapy or not, but that's really weird, and I haven't done anything different. So it's interesting. When you replenish those hormones, good things happen. Okay, low DHEA, again, deficiency. You start to feel bad. You start to lose your sense of vitality. You become more irritable. You drag around a lot. That's how it is. You go. That's the biggest difference right there. I'm sorry? We'll get into testing. Okay, other vital hormones. Cortisol. I talk about this all the time. This is the game changer right here. It is the foundation of the hormonal system. It is our body's natural steroid anti-inflammatory. Too much obviously leads to belly fat, diabetes, hypertension, all the medical conditions there. Too little, you're not going to be able to, your thyroid is not going to work. You're going to feel sluggish. You're going to have that weight gain. You're going to feel bad. It modulates the immune system, so you're going to feel like you get an infection all the time. There was a lady just the other day, she said, I started with the flu in November, and it's just like a sinus infection after sinus infection after sinus infection. I did a saliva test and looked at her circadian rhythm, and she was bottoming out. And I'm going, well, there you go. You don't have enough cortisol on board. So, too high, too low, not good. It needs to be in there. Okay? We're going to come back to this. And thyroid. One thing about thyroid, if you're estrogen dominant, it can cause hypothyroidism because estrogen competes with the thyroid hormone at its receptor. So remember, estrogen dominance. If you don't have progesterone to balance it will create fluctuations and imbalance with all of your other hormones. Okay, so why do we lose it? Well, because Mother Nature is designed to take us out. We are genetically made to die. And everything is going to start declining with age. Doesn't mean that we have to die. We can make that decision. All right, reasons for hormone replacement. Well, if you look at this point here, perimenopause, and progesterone starts to decline, this is when these young women start coming to me. Something is wrong. I don't know what it is. I cry. And I just get so sad. It could be anything. And my husband walked in the door and I'm ready to just fight. I'm like, yeah, there you go. And I'm sweating all night. I won't let him touch me because I stink and I feel bad about myself. Okay? And look at this. Oh my gosh. That isn't a reason on its own. Okay? You got estrogen going everywhere. And we don't know. We just don't know during that period. And I've got women now, that are pretty well balanced. Their estrogen and progesterone are really pretty well balanced. But they're going through that period. And it's hard. And there's no pattern. And that is the most erratic time right there. And I just, every time I think about it, about these women and what they're going through, I go, what if you hadn't come to me? And what if you hadn't had some progesterone? I can only imagine what your home life is like. Okay, more reasons. Hot flashes. Sleep, like I said, is the #1 problem. Night sweats. People are gaining weight and they cannot get it off no matter what they do. And it is a vicious cycle. And I tell them, I said, let me guess, Because they'll come in, they're playing, and they're like, you know what? I have not done anything different, man, but I am just gaining weight. I mean, it's just like, God, it seems like a passed away. And it's just like, you know, I don't, what am I doing wrong? And I said, let me guess. So you get on the scale, you get depressed, and you go to the gym. You sign up for the gym. You're there every day, 7 days a week, on the treadmill, killing yourself, 40 minutes each time, and you're trying to build muscle. And on top of that, you're eating little to nothing. Did I get it right? And they're looking at me and they're like, well, then why? Why am I not losing anything? I said, because, honey, you're not balanced. Until you get these hormones balanced, you will not lose an ounce of weight. Did y'all get that? Women, are you listening? Are you listening? Okay. Also, vaginal dryness is a problem a lot of times, and that's when the libido goes away. It hurts. You know, don't want to do it. Okay, these are some women killers: cardiovascular disease, breast cancer, dementia, osteoporosis. And notice how all of those are rare in premenopausal women. You know, when we're in our 20s, we didn't worry about it. We're out doing our thing, enjoying life, you know, partying like there's no tomorrow. We ate what we wanted to eat. We didn't gain an ounce, right? And then all of a sudden, you know, our hormones start declining, and what do we get? All these diseases that are taking us out. Because Mother Nature is designed to do that. And then the breast cancer rises. It begins at perimenopause, because that's the first hormone to go. Just after menopause, women's rate of cardiovascular disease rises faster than men's. That's why we get heart disease. Again, you know, more statistics. You can read the impact on bone. Menopause, 5% bone loss per year for the first 5 years. That's 25% bone loss. Just due to the loss of estradiol. I mean, that's huge. And we're living longer. Again, more studies. This one is on Alzheimer's disease, and based on the CASH study, I mean, hormone replacement is the single most powerful weapon against Alzheimer's disease. You've got to have these hormones to be able to think. Okay, reasons, more reasons. A lot of it is just add-on. Staving off chronic autoimmune diseases, age more gracefully, quality of life. That is the number one thing, is quality of life. They come in and say things, I am 40, 45, I'm 50. I am looking at my mortality, and I really don't like it. And I've got all these people in my family who have died of X, Y, and Z, and I don't want to be like that. Help me to stave off disease. So if menopause causes hormones to drop, low hormones cause aging and disease, then isn't it logical to replace hormones? Okay, history. In the 1930s, a chemistry professor, Russell Marker, who was at Penn State College, actually discovered a process using diasterin, which is a plant steroid, to produce bioidentical progesterone. In the 1930s. That's how long bioidentical hormones have been around. And of course, Bremer came along, you know, competitive years. And, you know, they started finding that replacing estrogen actually did improve memory and bone loss. And then, of course, in 2002, the Women's Health Initiative came along. Okay. Women's Health Initiative. That was a government-funded program study that was conducted with 16,000 women. And so some of the women were given Premarin or Prem-Pro, which has got the progestin in it. Notice I say progestin because it is a synthetic molecule. It is not progesterone, okay, which is bioidentical. And the study actually was cut short 3 years early, actually, because they discovered an increased risk by the women who were on hormones breast cancer. And they also found an increased risk of heart attacks in women on the progesterone early on in the study. So here are the results. Breast cancer increased by 26%, cardiovascular disease 29%, stroke 41%, blood clots 20%. Okay, and you know, it's interesting. The writing group for the Women's Health Initiative even said that it remains possible that transdermal estradiol with progesterone, which more closely mimics the normal physiology and metabolism, may provide a different risk-benefit profile. Now, these are the writers of the Women's Health Initiative who are saying. So they see it. All right, so let's go through some differences between synthetic, natural, and bioidentical hormones just to kind of give you the differences. Synthetic hormones are patented and they're conventional. They're not, usually not found in nature. But some are natural, you know, like estrogen. And it's not, definitely not identical in structure or function to the bioidentical hormone. And then you've got natural HRT, of course, with Premarin. You've got some phytoestrogens, soy products out there. But they're natural. They're phytoestrogens. They're not the real endogenous estrogens that you're making. So sometimes you have to be careful with those because they will, you know, compete at the receptor site and with your own endogenous estradiol. You have to be careful with that. And of course, bioidentical hormones, they do have the exact molecular structure as your own. So to me, it's a lot simpler. It's easy. You know, if your body can recognize it, it's going to do what it needs to do, and then it's going to be eliminated. It's a no-brainer for me. And bioidentical hormones are customizable for individual needs. And to me, that is the main benefit. Because no two persons are alike. So you're not going to react the same way. You know, and that's why our website is knowwhereyourx. Nobody here wears the same shoe size, right? Okay. One size fits all HRT. We just talked about that. Bioidentical hormones, they're not drugs. You know, they've got the same molecular structure. A lot of this is pretty much repeat. Here's the molecular structure here. Notice this is progesterone. This is an alien molecule. Here. Okay, benefits. Estriol, there's a lot of clinical data out there on estriol. It is a natural product, so it cannot be patented. And it is protective and safe at physiologic level. We lose 80% of it after menopause. And it is the most protective of all of our estrogens. So why should we not replenish? That doesn't make sense. There are less potential undesirable side effects than with conventional synthetics. And only 20% of the women who are on synthetic HRT actually stay on it. I mean, I've had so many women come in and go, you know what? I've gone that route, and it is not working for me. I had a lady just the other day come in, and she was in tears, and she said, you know what? I started having these issues. My husband said, you know, do you need to go see a therapist? Well, she said, no, I mean, I don't think there's anything wrong with my head. And wrong way. I was trying. And so, you know, she went to the doctor. The doctor said, okay, here, why don't you take this? It was a pill. And she gained, what did she say? She gained like 10 pounds in a month. And she said, oh my God, Sam, I feel so bad. I feel awful. I feel worse than I did. And so she stopped it on her own. She said, I'm back to being miserable, but I don't want to get back on the pill. Okay, so we kind of alluded to this earlier. Again, diastatin from Mexican yams, soy. So it is a natural source. So what are our goals with the HRT? We want to mimic normal physiology. So there's enough there to work the way it needs to work and to minimize the symptoms, menopausal symptoms, and to restore and prevent disease. Those are our main goals. I get that. You know, in our waiting room, and I like to make appointments back to back because I like my day to be filled up. And so women are kind of waiting in the waiting room, and it's funny because they watch each other and they know what the women are coming in for. And I've had a lot of women come in and go, how much did you put her on? I said, well, she's a little different than you. All right, so what throws us out of balance? All right, adrenal glands. Okay, this is the crux of the problem here. It's not just the decline in hormones, but it's the stress that comes with just breathing. Okay, we are alive, we are stressed out. Adrenal glands. There are two. Well, they're walnut-sized glands that sit atop the kidneys there, but man, they are responsible for so much. This is the adrenal cascade, and the reason why I have this up here is I wanted to show you what happens when we get stressed out with our hormones. Okay? When we are stressed, the body likes to pull everything in this direction. It has to produce cortisol, and it keeps producing cortisol to keep you going. Okay? But the problem is, when you are pushing so much cortisol, and the body has stopped being able to compensate, it's going to have to find another way to give you fuel. So how does it do that? It is going to look around and find this. And some of you probably are at the age where you're not making that much anymore. And it's going to steal it. It's going to rob that progesterone and convert it into cortisol so you can use it. But that's not good, because if that happens, then what happens to estrogen? Where's the progesterone going to come from? To oppose that and open up the receptor for the estrogen to come in. So that is one of the biggest problems as to why women become obese. And And when you're stressed out, all of these hormones will also start to dip. So you're kind of in a bind. Okay, effects of stress. Cardiovascular events, obviously, diabetes. A lot of people get cravings all the time and they don't understand. And they're like, I have my carbs at night. I can't help it. And I'm like, yeah, well, I see the results. It shuts down your digestive processes, decreases your immunity, creates memory loss. And a lot of people come in and they're just like, you know, I forget why I'm in the grocery store. I know I'm supposed to get something. Or I don't know where my keys, I can never remember where my keys are. It's not normal. Okay, and then you've got fatigue, increases free radicals, cell destruction, and of course autoimmune disease. Okay, so this is more of how your hormones are not in balance when cortisol is around. If you've got progesterone steal, everything else is not going to stabilize. You've got, for instance, progesterone competing with testosterone for the alpha, 5-alpha reductase enzyme, and then you need progesterone. You're making progesterone. So stress is going to decrease the amount of progesterone you make, and you are going to start making more dihydrotestosterone. And that actually has been linked to prostate cancer. So stress is very detrimental. Cortisol can be very detrimental. Decreases TSH and free T3, decreases progesterone in the endometrium, so it increases estradiol. So you've got all the imbalances, all because of one hormone, and it's your stress hormone. And it's interesting, women who are going through perimenopausal transitioning, because, you know, at some point that manufacturing plant is going to shut down. Well, do you think that you just stop making hormones once your ovaries shut down? Who in here thinks that we just stop making hormones? That's right. We make hormones, we have to, but it's in a different place. And it's in your adrenal gland. And if it's responsible for making stress hormones, and the stress is going to create imbalance, what do we need to do? Okay, more hormonal imbalance. Pay close attention to coffee, alcohol, lack of exercise, and insufficient sleep leads to an increase in cortisol. A cup of coffee raises cortisol for 48 hours. Caffeine. Yes. Okay, inflammation. Stress and inflammation. Stress increases inflammation. Inflammation creates cell destruction. Cell destruction creates disease. Simple. And there's your hidden timeline. And then we've got insulin resistance on top of that, which is high stress in the body. We end up with metabolic syndrome and, of course, diabetes. Cortisol, melatonin. I love melatonin. Don't you? Helps you to sleep. But the higher the stress, the lower the melatonin level. This is how it is. So you've got to figure out in your stressful life, what do we need to do to decrease that stress so that you can start to at least bring up that little bit of melatonin that you make. And if you don't sleep, you don't eat. Okay, cortisol and thyroid. If cortisol is too high, you got a problem. If it's too low, you got one, it's not work. So you end up with everything, with all of these issues: tissue resistance, adrenal exhaustion. So 80% of the people with adrenal fatigue will also have low thyroid function. So you have to support the adrenals first. And a lot of people want me to throw hormones at them right off the bat when they come in. They're like, "Damn, I know it's hormones. I can't think. I'm having all of these symptoms. I'm fighting everybody. I'm crying all the time. I don't feel like myself. I can't sleep. Can you just give me something?" And I'm going, "Okay, tell me about your life. What are you doing?" "Oh, well, I'm a teacher. And I have 5 children." You know, and I have to take care of my elderly parents. I'm like, "Are you kidding me right now? I cannot do anything for you until you start to find some time for you." And you know, you cannot tell me that you can't, because you can't. If I can do it, anybody can do it. Okay? And it's even just 30 minutes or an hour a day that you can sit down by yourself, no cell phone, no TV, no stimuli, no dogs, no children, and definitely no spouse. No significant other. You've got to just have that time to yourself where you can breathe, because when you can do that, you are saying to your brain, "Relax. Do not send signals to my adrenal glands about universal." That is what you do. And you know what? You'd be amazed at how your hormones will start to come back. Functioning will start to come back, and you won't feel so bad. All right. So, symptoms of adrenal fatigue, low energy fatigue, excessive fatigue, easily overwhelmed, allergies. I get a lot of anxiety issues. People can't sleep. Obviously, all the things that we just talked about, a lot of cravings, digestive problems, weight gain is a big deal. Okay, and some of these are the typical cortisol response patterns. Sometimes it's really high in the morning because there's that stress at night because you haven't slept. So you're tired in the afternoon and wired at bedtime. I'm getting ready to show you from the graph. This is a normal salivary cortisol profile. Of all the times that I've been doing this, I've only seen maybe 2. And those people really didn't work, and they took care of themselves very, very well. This is cortisol insufficiency. I see this a lot. I mean, you barely got started. Look at that. You can't even wake up. What are you going to do the rest of the day? That's right. So your body doesn't understand. I mean, it's like this number and this number are kind of within the same range. You don't want that. It needs to be higher here to wake you up. And then you're supposed to function throughout the day, and it's supposed to get lower, be at its lowest at night so you can sleep. That's the goal. Okay? This is another typical one. Too high in the morning, and then it dips. Okay, as far as cortisol restoration, if it's a mild deficiency, then what I tell everybody, you know what, you need to rest. You need to find some time and just figure it out. Take something out. Just one little thing at a time. Okay? And some nutrients. I put them on some nutritional supplements to help your adrenals get that function back. But if it's moderate to severe deficiency, yes, sometimes I have to pull out the big guns and out of cortisone is the way to go. But I only put them on that for a short period of time. And usually it's the flatliners. People who just can't get started. And if you can't get started first thing in the morning, then how are you expected to find the energy to go work out? Right? So we got to get you motivated and going. And so we give them a little bit of oral hydrocortisone. I like the sustained release formulation. Get them going for about, depending on how severe it is, but I don't keep them on it for a long period of time. Sometimes 6 months, maximum a year. And then we start pulling them off. And if you're interested, you can read Dr. Jeffrey's Safe Uses of Cortisol. Okay, some nutritional supplements. Magnesium. I put everybody on magnesium. It is responsible for 300 enzymatic activity in the body. Why would you not want to give people magnesium? It is the most benign mineral. Wonderful. It helps people to sleep. It relaxes them. That's why, a lot of people who have aches and pains, leg cramps, magnesium works great. We start them on 400 milligrams at bedtime. These women love it. And if you've got constipation, jack it up. Increase it, until bowel tolerance, back it down. And it's great. Vitamin C is wonderful for adrenal support. B-complex. Women who have ever been on birth control pills or on any HRT, any form of HRT, will be deficient in B-complexes. And I put them all on B-complexes right off the bat. B5, great adrenal support, and it also helps to make your hormones. Okay, GABA controls brain excitability, helps to calm down. Zinc is wonderful for the immune system. It's also good for adrenal support, but it also helps in hormone production. Omega-3s, fish oil, everybody's on fish oil. And it's a wonderful anti-inflammatory, supports everything, cardiovascular health, brain and nervous system. So these are basically the nutrients that I put everybody on. And vitamin D, I just added that. Some of you are probably not familiar with IPC or Zoom. These are supplements that actually help the body metabolize estrogens a lot better. And I use it when women come to me after being on permethrin or any of the synthetic, any oral progesterone, any oral estrogens. I just give it to them. Okay, let's do it for 3 months, 6 months, whatever, depending on how long they've been on it, because they are more than likely not metabolizing the estrogen well. For human, great inflammatory, anti-inflammatory, and you've got zinc, selenium, you've got to have those to activate your vitamin D2 to activate your thyroid. Of course, diet and lifestyle is the same old thing. Good junk, fruit juices, you don't want any insulin resistance. That puts stress on your adrenals. You need 7 to 8 hours of sleep at night. Get that circadian rhythm going again. Eating, more organic, antibiotic-free type foods. Drink lots of water. Exercise. Now, remember, if you've already transitioned over as far as hormone production to your adrenals, you have to be very careful with exercise. And we're just ingrained, I think, to think, well, gosh, I've got to lose, X amount of pounds, so this is what I'm going to do. There's going to be a calorie deficit, I've got to push myself harder, because if I did that, then I'm going to lose that weight. You will probably lose some, but the stress that you've just put on your body is going to pretty much create this huge imbalance overall that is going to be harder You're going to lose it, gain it back, and some, and then it's going to be harder. So I'm just telling you, it's different, as far as exercise. More yoga, more relaxing type exercise. Cut it down instead of 6 days a week. Do it 3 days a week, but make it count. Do it for you. Don't do it for anybody else. We need to be doing that. Okay, adaptogenic herbs. I use a lot of adaptogenic herbs in my practice. It was a term that was coined by a Russian phytopharmacist, Dr. Nikolai Lazarev, in 1947. And these herbs actually help the body's resistance to stressors. They kind of adapt to your body to help you balance out that cortisol, because the cortisol is the problem. And these are some common adaptogens that I use. And just know that not everybody's going to respond to these adaptogens the same. When I first started, I was thrown, with all of these in. Somebody just threw it out there, and I was like, well, God, what am I supposed to use? And I've just realized that you start with one. You start with one and say, listen, this is going to help you handle your stress a lot better. And people love it. Now, if they come back, let's say they're on therapy, and they come back, and they end the adaptogen, and they come back after 2 months, and they're just like, something's just still kind of up and down, and they can't seem to control it, and they're trying at home, then that one adaptogen may not be enough. Or it may not be the right one. And that's why sitting down and really talking to your patient is important. Once you get all the information, it's a lot easier to put them on the right therapy. Additional supplements, phosphatidylserine is another favorite of mine. That stuff just makes people relax and sleep. I've had people who haven't slept in 30 years. I balance their hormones, put them on phosphatidyl, and they're sleeping like food. And they cannot, they don't want to ever get off that. I said, all right, that's fine. It's a naturally existing phospholipid in the brain. We actually, we make these phospholipids, but over time we lose it. And that's why we've got some cognitive decline. So I'm like, okay, well, take the phosphatidyl, it's good for your brain, and it's good for helping you handle that cortisol, balance it out. Magnesium, Z, melatonin. I give melatonin, but I think a lot of times, if you can support their adrenals, get them sleeping, shut down that cortisol at night, and once their circadian rhythm starts to change again, and starts to improve, you don't really need a melatonin. But sometimes I'll put them on it. It's been stuff for 30 years. I do that. Okay, adrenal recovery, mild is 6 to 9 months, moderate is 12 to 18 months, and severe, over a year or two. And that's one thing, when I sit down with my patients on the front end, I always tell them, I said, now, you did not get here overnight, so you are definitely not going to recover overnight. So just be patient with your body, and we're going to take it slow, but anything that is worth it, then it's worth taking your time on. And most people understand that. And when I tell them, the adrenals don't bounce back quickly, especially after the age of 40. So don't, I have one lady right now that's a little difficult because she has had adrenal dysfunction for about 20 plus years. And she came to me because nobody else was listening. And we put her on a little bit of hydrocortisone. It was a sustained release. She was really, really low. I put her on the sustained release, 10 milligrams in the morning and 5 milligrams at noon. By the second week, she was freaking out. So she called me and she said, well, Zoom, I'm really tired. I'm just really tired. And I'm going, what do you mean you're really tired? You can't be tired. I'm putting you on cortisol. You can't be tired. And so with further investigating, I realized that she had gotten some of her energy back. And as a result, she started doing more. So instead of one thing, like I told her, just focus on one thing a day. And just get up, go to the mailbox, walk to the mailbox, get your mail, come back. Okay? Because I mean, her adrenals are so severely fatigued. Well, she said, well, you know what? My daughter's getting married, and I had to do this, and I had to do that, and I had to go to the grocery store, and on and on and on. And I said, nope, I'm not doing that. And so we had to start again because her adrenals didn't have the adequate time to really bounce back, not even to really begin again. And she had a little bit of energy, and she decided, well, I'm gonna do things. I feel so good. I can do it. I can get out and be Superwoman again. So, but it's also the personality. So I've had to really work with this patient, and it's almost like a weekly consult with her. Okay, measuring hormones. You've got to have a baseline, just so that you know where to go, where to begin. I mean, symptoms are important, but you've got to have something, some data. And I don't care really what you do. I mean, I do saliva testing because it is the gold standard for hormone therapy. But I don't care what you do as long as you do it consistently. And just remember, if you are putting people on transdermal stuff, the blood testing is really not going to get you there. It's not going to show up. So you'll need to use saliva testing. Okay, so why use saliva? Well, saliva testing measures the most bioavailable, all your free hormones. So why would you not want that? When you do a blood test, what happens is all the hormones are pretty much rendered inactive because it's carried by carrier proteins in the blood. And so you get like a very small percentage of free, and there's this huge wide range, and you can fall anywhere on there, and the doctor's going to tell you, well, you're fine. You tested fine. You're normal. But you know with your symptoms you're not. And with saliva testing, the range is a lot narrower, because it is. It's testing just for your free bioavailable hormones. And it's a lot easier to gauge therapy as to where to begin for a person with a lot of symptoms. Okay, so a need for compounding. Well, a lot of the synthetics out there are giving people problems. They're getting side effects that are unwanted. And patients are doing their own research now. And there's a lot out there now. I hate to say it, but Dr. Oz and Oprah and Suzanne Summers kind of brought that into the forefront. And they're realizing that they've got an option. And they're finding out that the option potentially could be safer. They don't fully understand it, right? They just know that if it's natural and if it's the same molecule as their own, then it's got to be better. So they're doing their own research, and they're coming in, and they're saying, listen, I've read up on this, and my doctor's gonna approve this. And that kind of opens it up for you guys. It's a wonderful niche. And one size fits all, HRT does not work for everyone. Okay, so the controversy. So the 2002 Women's Health Initiative study, that's what just got everybody, physicians and patients. I think what really happened was, it leaked out into the media. The media really did not fully explain the study. And they didn't really say, well, gosh, this was a study based on some synthetic hormones, and they were oral estrogens, right? They just said, hey, they grouped everything together and said all hormones are bad. And women have been terrified ever since. They're like, well, gosh, they say that, hormones give me breast cancer, and I've got breast cancer in my family history, and it creates heart attacks and cardiovascular risk, and uterine cancer, and on and on and on and on. Well, no, not bioidentical hormones. That's not what the study is about. And I've put in here some of the arguments, the Academy, the College of Obstetrics and Gynecology. I mean, they had to cave into formal pressure and basically wanted to win everything. They said, well, they're all hormones. They all are progesterones. I won't go through all this. Yeah, the North American Menopause Society, they're basically wanting everything grouped together as one, so that there's no confusion. But you can't do that. Of course, the drug companies, that's their deal, money. There is evidence, that bioidentical hormones do work, and they work very well at physiologic level. And I would check that out. Kent Haldor's study on progesterone and the efficacy of progesterone, of bioidentical progesterone versus the synthetic progesterone. And he found that there was greater satisfaction with progesterone compared to synthetic progesterone. And these are wonderful results. We just talked about that. There's a lot more choice. And people are listening. They're hearing it. Okay, need for compounding. Obviously, the phase of the hormonal change, women are going to start having symptoms. So that's an in for you. They're going to come and ask you. If you've got a retail pharmacy, and they're coming to get their prescriptions, that is a perfect way to talk to them about that. Now, I don't volunteer information because I don't think that's right. But a lot of my patients have been loyal patients that I've talked to and nurtured over the years. And so, they'll ask me, well, what do you think of this prescription? And that's my end. That's when I can say, you know what, based on clinical evidence, and, again, you've got choice. I'm not saying that one's better than the other, but I will give you the differences, and I do have clinical evidence if you just want to read it, or if you want to take it to your doctor. And man, changes people's minds. Lots of options. Oh my gosh, there's where the transdermal, pellets, vaginal creams. The basics of DHRT compounding. Transdermal is preferable. You want it to go in, get into the tissues, work, and leave. You don't want it going through the liver. You don't know what's going on there. You've got some lingual drops, these injections, implants, and there's so many options, still more options. Okay, this is the terminology that we use in compounding when we're doing estrogens. I use biased, and it's going to vary with every practitioner because of the individual and what they need. And bias is a combination of two estrogens. You've got the good, the estriol, and the estradiol, which is the most potent estrogen. That's the main estrogen that once you replenish, your symptoms are going to go away. Okay? So we can have anything from 80-20 to 50-50, gosh, I've seen 60-40, 70-30. And the percentage is broken down. So you want more of the good protective estrogen. So be like 80% estriol, 20% estradiol. You don't want a lot of estrogen. Remember, we're already estrogen dominant. We start becoming estrogen dominant probably around 35. So we don't need any more estrogen dominant. We want a little bit of that, more of the estriol, the good one, the protective one. Okay? And usually, if they have vaginal symptoms as well, and that's when I switch my percentage. Because they need more estriol there. Okay? But if it's topical and their symptoms are pretty traditional, then I use a 50-50 and it works great. Typical dose ranges, these are typical, but in my practice, and I don't ever use a trias. I just put it up there because there are compounders using this. A trias is really a combination of 3 estrogens, and that estrone is added in there. I never use estrone. Estrone is a carcinogen. Unless the woman who comes in is about that big. I may put a little bit of estrone in there, but then I pull her off like probably within 6 months. I do not like estrone. You already make it, so why add more fuel into the fire, right? Twice a day dosing, I have not seen a lot. I don't do twice a day dosing. I don't think I have anybody on twice a day dosing. Usually once a day is fine, unless there's breakthrough hot flashes or symptoms during the day. Something like that, then we may have to split the dose, but I have not had to do it. Progesterone is wonderful. You can do it at immediate release or sustained release. Either from 50 milligrams to someplace 300 milligrams. I go up to 200. The beauty of progesterone is it helps you sleep. And oral progesterone, especially, because there's a metabolite, a specific metabolite that once it's broken down, it helps with sedation and the calming effect. And most women love that. I had a teacher who actually just could not sleep. She just said, I am like wires all the time. She's like, I can't shut things off. So, well, you've got an adrenal issue. So I'm going to, give you some progesterone. But now, you're not going to need this all the time. We're just going to see how it goes. So I figured I was going to pull her off like in a couple of months, kind of get her sleeping, and then got rhythm back, and she'll be fine. Well, on the follow-up, she said, you know what? I don't think I want to keep this up just yet. I said, okay. You'll know when. And she is sickly. So, of course, teachers are there all year. They're stressed out all the time during the year. And then summertime comes, and they get a break. And what happens? They're not so stressed. And so she was able to sleep on her own, so she could skip it, like in the summertime. Some of these are cyclic. It's the person, remember, it's the individual that you're caring for. Testosterone, I don't mess with testosterone unless you were really low. And then I have to balance that with DHEA. I have to kind of look at things. You just don't throw testosterone at people. You need it. That's why, that's the whole point, is to replenish what you need, no more. And there are women who come to me and go, I need something for libido. Gosh, we're in trouble. And I'm like, and that's the first thought, is, can you give me some testosterone? I said, I can't give you anything without the doctor's permission, first of all. But second of all, testosterone isn't your trigger hormone. You are totally not well balanced on the progesterone and estrogen side. So until I get, first of all, fix your adrenals, and then get your estrogen and progesterone balanced, there is no amount of testosterone that I can give you that is going to get you back. And first of all, you've got to like your spouse. And if you don't like him, there's really nothing I can do for you. That's counseling, and I don't do that. Okay. All right, transdermal versus oral. Again, this is just giving you the differences with absorption. I don't like I said, I don't like oral estrogens, period. The risk of blood clots is enough. First pass, and stuff. You don't have to read all that. Okay. Yep, and you know, the only oral that I do really is the progesterone, the topical. I do everything else pretty much topically. And it's so wonderful to be able to tweak the doses because, you know, you're always going to know after about 2 months. I mean, it takes about 4 weeks. Sometimes, you know, people do get better. I mean, I had a young woman who had some adrenal fatigue along with all the hormones. She seemed like she flatlined across the board. Everything was low, her cortisol levels were really low, and put her on therapy, started her on cortisol. 2 days later, she called me, she was crying on the phone, and I thought, oh my God, what did I do? And she said, I just want to thank you. I don't know what you did, but I actually slept. Like I went to sleep. Like I fell asleep at 10 o'clock and I actually woke up at 6 o'clock. I don't know what you did, but I just want to thank you. And I said, thank your adrenals, because they're coming back. It's that hydrocortisone that's nurturing those adrenals and supporting them to where it's starting to help you. You're so dry. When your body's dry, it's going to start to just suck it up once the hormones get in there. And vaginal creams, I mean, that's been a godsend for a lot of women. Vaginal dryness and painful intercourse. I mean, I'm just telling you, that has worked beautifully. And just with the dryness alone, when we supplement with some combinations, actually it can get libido back as well. Okay, so progesterone dosage forms again. I do the sustained release, but it really depends. I mean, some people have slept for a long time. I'll probably use the immediate release, just to kind of do a little dump and get them moving in that direction. The creams, again, there's really no real standard as far as dosing. And I guess that's why training is really important and also personal experience. You kind of start low and kind of go from there because people will respond. It's amazing how a little bit goes a long ways. And when I tweak, I do not tweak big. I would go with 0.5 ml. Oh, go ahead, jack it to 1. I go 1/10 of a point. So, we'll just go up to 0.6 to see how you do in a couple of weeks. Okay, and it's amazing. Even in that 0.6, I had a patient of mine, and I was doing a speaking engagement with the hospital, and she's kind of stopped me afterwards, and she said, well, you know what? I feel kind of weird. Something's changed, and I just need your help. What do we need to do? And I said, those symptoms kind of sound like you're a little estrogen dominant. So why don't you just go up by 0.1? She didn't believe me. I mean, you could tell. She was like, oh, wait a minute, that's nothing, right? Well, about several days later, she came back in, and she was all happy, and she looked at me, and she said, I really didn't believe you. And I'm sorry that I didn't. Because that little bit made the biggest difference. She said, I am much calmer. I don't feel, that edge anymore. So you don't need a lot. Physiologic levels. Let's see. Yes, testosterone. Some lingual troches, we use some of that. And gels, creams. We do a lot of creams for women, but I use a very small amount of testosterone. You don't need a whole lot. For men, it really depends. Again, adrenals play a big part in that. If I've got a really stressed out man, I am really going to put him on nutritional supplements right off the bat. Give him phosphatidyl pretty much based on the circadian rhythm, wherever he needs it, because it's the cortisol that's creating the low testosterone. So I can throw a bunch of testosterone at him, but he's not going to get it. Until I handle the adrenal side, nobody gets better. If there's anything that you need to take away today, that is the message. Okay? Your adrenals play a huge role in hormone balance. And if you don't fix that, you will never be able to fix all of your hormone imbalances. And with men tend to aromatize. They convert their testosterone into estrogen, and when they are stressed out, they will do more of that. If they're insulin resistant, they will do more of that. I can always spot it. They'll walk in, and fortunately, there's a bit of a gut. They're tired. Had a man just the other day come up to me, they always like to do that. Women love to talk. I mean, they'll just come up there, Sam, I've got a problem. Help me. I'm not sleeping. I'm not having sex. And I mean, they'll talk all day long. And then, this is the best one. Sam, I need to talk to you. And so I'm like, okay. So I'm coming over, and they're like, I don't really know how to ask. And I'm like, well, just ask me. Tired. That's their little word for I'm not getting it. And so I go, okay, so you're tired. Break it down for me. How often? Nothing. Okay, got it. All right, let's do the test. Let's get you in here. It's so weird, when these people come in. With women, I'll spend a whole hour. Well, let me get started. In 1950, this is what happened to me. And then it just all went downhill from there, too. And then for men, it's like, I'm just here. My wife sent me. I said, oh, okay, well, why did she send you? Well, she says I'm a little grumpy. I said, okay. So she wants me to fix your grumpiness? Yes. And, if you can, I'd like to, And I'm going, get your libido back? Yep. Okay, 5 minutes. 5 minutes. I kid you not. I have to pull things out of them. I have to go, okay, all right, where do you work? What are you doing? What kind of stressors do you have? Talk to me. My God. Okay, a little more. Do you have good relations with your wife? Okay, I mean, what kind of diet are you on? Do you drink a lot of alcohol? I mean, it's like I have to pull everything out. And then at the very end, it's like I notice on their chart, oh, you're on a statin too. Great. Well, there you go. Not making cholesterol, not making sex hormones. Here you go, that's your problem. Okay. All right, so this is what I did. For the patient evaluation and assessment, the way the program, my program, is if you come to me and you ask me or say, listen, I got a problem, I need to see you. And I go, okay, you need to go on my website. There is going to be forms on there that you need to fill out. I need to know a little bit more about you. A medical history form that tells me your medication history, hormone history, lifestyle, all of that. See how stressed out you are. And then it goes directly to my email. And so I assess it, and then I send it to a staff member who calls and makes the appointment for me. I have tried doing the appointment thing on my own, but that was not so good. I kind of messed it up royally. So now I've just got a girl doing it who's super organized. And so once they make the appointment, it's about 30 minutes to an hour. Like I said, usually with women it's an hour. Men, it's 5 minutes. Maybe 15 minutes. And we go over the medical history form. You know, I kind of ask some questions to see what's going on. And then they do a saliva test. Pick up a saliva kit. One of my girls goes over it with them and usually comes back to me, I don't know, 7 to 10 days. And then I have to assess it. And based on my consultation with the patient, because again, the patient is the one you're caring for, not numbers. Always remember that, okay? And so once I get the numbers back, and I've already talked to you, then I kind of come up with a care plan. And that care plan goes to the physician of choice. Notice I said physician of choice, because it's not always their gynecologist. Because unfortunately, not every practitioner is able to do this right now. And so if they've got a primary care physician, great. Who's open to it? Wonderful. And that's why I put in here a lot of the clinical stuff, studies, if you need it, if the physician needs that information, you can always pull it out. Okay. And I've had patients to ask me for a copy of it so they can take it to their physician. And I always tell them, I said, listen, please get the physician to call me. I will be glad to talk to them. And the tides are turning. Okay, symptoms evaluation. These are just, that's the key. All the hormone symptoms that I use. Saliva, which we kind of talked about, what I do. And these are the FDA-approved bioidenticals, which don't really work effectively long term, because your hormones do change. You've got standard dosing here. One size fits all again. And of course, we know the disadvantages. You can't adjust anything. And there's no transdermal progesterone available. Definitely no testosterone that's out there. And you can't combine hormones. If you do that as well, and I will not combine any hormones until after 2 months. Because you're going to see how they react to them first. And if you combine the hormones, you cannot treat them effectively. Okay, so if they've got estrogen dominance symptoms, and you have to kind of up their progesterone, how are you going to do that if you combine the bias and progesterone together? If you go up on progesterone, you're going to go up on your estrogens as well. So you don't want to do that. Compounded bioidentical hormones are, they're not regulated by the FDA, they're regulated by the United States Pharmaceutical. Okay, so, you know, a lot of people go, well, well, yes, they are, the powders are, okay, but compounding is not regulated really by the FDA. Customized delivery, same stuff. All right, so where to begin? If you've got a retail pharmacy, that is really your best bet, because they'll come in with prescriptions, and you're on the front line receiving them. So that's a good way to talk to them. And you can always tell, some of you people are a little hesitant, they're a little scared to take it because they're already on a bunch of drugs. So they're like, you know, it's one more thing. You know, can you tell me a little bit about it? Can you give me your opinion? That's your in, right there. And get your staff in place. Your staff has to be in place for this, because it is a lot of administrative stuff that you got to do. But once you get the flow going, it's really simple. I mean, it's just, it works like clockwork. We get calls, you know, my assistants come in and help me. The only time that I really spend time with these patients is when they come in for that appointment. Okay? I do not pick up the phone. My assistants do. And the assistants are trained specifically on how to handle certain situations. And they cannot give any clinical data out without my approval. I had a patient who came back for her 2-month follow-up, and she was a little nervous. She said, you know, I've been talking to one of your assistants, you know, every time that I've called. I just want to be sure that the data that she's giving me is from you. And I assure everybody that they know it. They cannot give any data out without first running it by me. Okay. If you're not trained in compounding and you're interested, PCCA is fantastic. It's the Professional Centers of Compounders, Center of America. And we absolutely, I'm going to tell you something, that is top-notch. They are top-notch in what they do. And I have been trained under them, and I'm going to tell you, every penny that I put into that group is not wasted. I've learned more. I mean, they always bring in the big guns when it comes to specialists, giving me data, top-of-the-line data at all times. That's how I know that saliva testing is the gold standard. And you've got physicians, practitioners all over the country doing it. Just so you know, bioidentical hormones have been around, gosh, they've been utilized for 60 years in Europe. Why are we behind time? Let's see, if you're a compounder, attend the CMEs. Like I said, all of their seminars and symposiums are fantastic. Incorporate as you go, one prescription at a time. Don't feel overwhelmed. Take one patient. And you know, I always say, the best thing to do when you're starting is get a family member. I know somebody's got a family member with these issues, okay? And I'm seeing younger women having these issues because look at all the environmental toxins we've got, the food that we're putting into our bodies that are, you know, that are laden with hormones. I mean, adrenal issues are everywhere. Everybody's got some. And it's creating these imbalances early. Younger. I've got a 28-year-old coming right now. Issues. So just take one person, help them, talk to them, and get them better. And it would build up your confidence. Marketing. We do all sorts of marketing. Oops. We've got a box fan. I've got all these questions up there with check marks. You know, weight gain, headaches, hot flashes. You having any of these symptoms? Thyroid disorder? You need to call us. We do commercials. This one, so I write in a couple of local magazines. And I write specifically on hormones. And people read them, and they look forward to them because it's always something new that they can use. And these are just some forms of marketing that are easy. You know, you can do brochures if you want to, which is fantastic. If you see a lot of people in your pharmacy, that's a great way. Bag stuffers, awesome. Train the staff members that have the most charisma. Get them out there. Get them in front of these people. Talking to them, and put signs up in your pharmacy. It doesn't take a lot, and amazingly, and if you keep doing the right thing, word of mouth is the most powerful. Speaking engagements, I do a lot of that, civic groups in the community, and groups with you, women's groups, church groups. So success begins with your heart. So start with caring for one person, and then all of a sudden you're going to be like, hey, I did something for that person, and they're getting better, so I'm just going to grow it. And it'll be the next person, and the next person. And it's amazing. After a while, you just have practice. You're like, whoa, great. So more importantly, don't look to become a person of success. Look instead to become a person of value. And I do believe that value precedes real success. Because it's about how you feel about yourself. You got to feel good about you to be able to feel good. Okay, and I've got a lot of reading material there if you're interested. Thank you. Any questions? The question was, with all of the testing, saliva, blood, and urinary testing, she wanted to know the cost. As far as saliva testing, it depends because there are different panels. So you're probably looking anywhere, I said it was just basic test, I would say anywhere from 100 to go up to $500. Just all the same. Okay? And again, that's when they come to you and you're talking to them and you realize how they've got this issue, so you go from there.